I'm Patty Gerrity. I'm the Associate Dean for Community Programs in the College of Nursing and Health Professions at Drexel University. And I'm the founder and director of the Stephen and Sandra Scheller 11th Street Family Health Services Center in North Philadelphia. I think was something that was sort of in the back of our minds for a long time, but I think it started when we were looking at middle-aged women with diabetes, and we screened for depression and realized that no matter what we did for the diabetes, it wasn't going to get much better unless we dealt with some of the underlying issues, and one of those was depression. So many years ago, we started a depression group for these women, and they became very strong together, and they actually gave themselves a name. They called themselves the Backbones, and they realized that they were the backbones of the community. And we had a really good therapist and facilitator for that group, and they really gained a lot of trust, and they opened up, and they started to talk about their trauma. And although they knew each other from the community, each one thought they were the only one that had a history of trauma and abuse. And so that came out of that group, and the group was for them, but they taught us a great deal. And another example is some of the children we saw. And I just remember very distinctly this one little boy, and he was living in the Salvation Army shelter, and his mother kept bringing him in because he was having more, physical issues and wetting the bed. And luckily, we had some really good people who were working with him, and rather than sending him to CHOP after a while for urological workup, they started talking about what was happening, and the little boy saw his mother stab her boyfriend. And it's two very different incidents, but really made us say, we can do all we want in regular clinical care, but until we address the trauma, both of the individual, the family, and what's happening in the community, we're not going to make a lot of progress. So I think those are two examples. There's many more. Well, many changes have occurred, but it was a long road. So this is 2016. I think we started working on this in 2008. And we worked with Dr. Sandra Bloom, and she was helping us and worked with the entire center on sort of Trauma 101 to let everyone know about it. And then what happened was, this was great, but then people at the center, some of the staff, started to get annoyed with me, because once you know this, you feel an obligation to do something with it. So what are we going to do? What's the next step? They kept asking us that. And we did get some funding, and we did a full replication of the ACEs study in our adult clients, and found that our clients had a much higher rate of ACEs than the original Kaiser study. We did that. We started to say we need some programs. We integrated behavioral health into primary care to make that readily available for everyone. And then Dr. Bloom suggested, she continued to work with us and suggested we do the whole sanctuary program. So we did enroll in the sanctuary program. We're still working on that. So that started to educate the staff and how we work together, and then how we would present ourselves to each other and to the patients. And then we started more programs. Unfortunately, right now, they're not all reimbursable, but we found that the creative arts therapies was very valuable and very effective for people with trauma. We also started working on a life course perspective and looking at women when they're pregnant, and really you can start anywhere, but we were really looking at them, talking about what happened to them when they were a child, what they want to repeat and what they don't want to see repeated, and we're trying to build strong, resilient families by starting with the pregnant women. We did some public art with mural arts around the stigma of behavioral health. That then opened up dialogue with the community about mental health issues and trauma, and we included children that were referred from the guidance counselor at the Spring Garden Elementary School. At the second year, we looked at the dimensions of health with those children, and now about 25 of them are in art therapy. And the feedback we're getting from the school is that it's really helped the children, their behavior, and their readiness to learn and act in the classroom. Another change we made is at the 11th Street Center, we involve our community. We don't tell the community what we're doing, we involve them. And when we wanted to do the ACEs study, we took that idea to our community advisory board, and they said they felt that we were there long enough, that it was safe and people trusted us, and they really would give pretty much, accurate responses. But what was really interesting is when we finished the study and we reported the findings back to the advisory board, although they were sort of on board with this, they all opened up about their own trauma. And we have a lot of reporters and visitors and filming at the center, and they know that. They're often involved in it. And they said, if we can do anything to bring more attention to the trauma and resources to respond to the trauma, I'll tell my story. I'll tell about my 10 years when I was incarcerated for something I didn't do. I'll tell about my multiple sclerosis and what happened to me as a child. I'll tell about what happened to me when I was growing up. And it became very open. And not only were they open, but they're willing to tell anybody their personal stories in order to bring more resources to the center. We then worked as part of the sanctuary with our advisory board and did most of the sanctuary program with them. Then they did the same thing the staff did. Okay, now that we know this, what are we going to do? What are the next steps? So 3 of our advisory board members have been very active in this, learning about it. They went to the Camden Summit. One of them went to Washington to the faith-based trauma program. And now we're working with the Community Education Committee, the ACEs Task Force, to say, how can we spread these messages in our community? So they're very involved. So it really takes both. Many things. It takes the health center, the providers. It takes the patients who are coming in to understand why we're asking these questions. And it takes the community to support that and try to really expand the knowledge and what we can do to support these building of the strong, resilient families in the community. I think you have to have support from the leadership of the organization, and you have to be ready for what emerges when you start building safety within your organization. Because once people feel they have that safe space, things are going to come out that you might not want to hear. And they're the important things. And so, for instance, what happened at 11th Street is one of the things that came out early in the core team was the issue of race. And we were so concerned about getting through the first years, the implementation manual. We said, that's a big thing. We'll look into ways of doing it. We'll put it on the parking lot. And we did that. But it just kept coming up. So we have a committee now on undoing racism within the center that has taken quite a leadership role. And that undoing racism is not just about race, it's about power and privilege. And they had a major say in our hiring process and what we were doing, and they continue to meet. And I think it's important that we address these issues, because if we talk about safety, sanctuary trauma, that's really an ongoing piece that often is difficult to address. And so that was a big thing. Sort of in summary, I'd say be ready for what happens and to be open to it. Also, looking inward. And I've been thinking about this a lot, and we're looking at, now that we've expanded the center, in getting more patients to use the center. And when we've really thought about this, we thought, if our experience is really exemplary, if we're truly working in sanctuary, and we are sensitive to the patients, and we are truly present for them, that experience will be enough to bring in more people. So although marketing is important, we've really been looking at ourselves and looking inward at how we provide services. And I think other providers sometimes need to do that and make the services centered around the patient and not for the ease of the staff. We've even made a change just Friday we're looking at the role of the front desk, because that's who greets everyone. And this safety has to start from the minute you make a phone call. So they're now called patient care representatives, and they're happy because that's really what they do. And one of the front desk is on the core team. So I think a lot of it is changing within and truly believing it. And when you do it and act on it, then the patients and the surrounding communities see that. I would also say, we've been thinking about this and writing a new mission statement, and we always said trauma-informed care, and I'm starting to think that shouldn't be in the mission statement, that trauma-informed care should be part of what we do and doesn't have to be specified that way. If we're really good, it should be like a vital sign. It should be a major part of the screening we do. And we don't have to say that. And I think if we get to a point where it's assumed that you'll be trauma sensitive and trauma informed, I think that's better. I think another thing is not to look at toxic stress, building resilience in many programs that you do. So I'm reluctant to take funds from drug companies. And they had a grant to reduce cardiovascular risk in adolescents. And I said, we'll never get this, but I'll apply. And if we look at what one of the highest risks for cardiovascular disease, it's toxic stress in childhood. So I'll write it for what it really is. And I'll say, okay, we have to work on nutrition and we have to work on exercise and activity, but we have to build resilience. And so I wrote that and thought we'd never get it. And we did. And so now we're really looking at the adolescents and how do we work with them to build resilience while they're doing the other things. And we put a community project in with part of it. So 4 of the weeks they're spending with us after the 8 weeks in the program is to disseminate this and to try to do a community service project with the information they're learning. So I say this to say, I think it shouldn't be an afterthought, but if it's what is truly driving some of the healthcare, we need to put it into most of our programs. And another thing we saw is in doing sanctuary, it sometimes was a little difficult in embedding some of this, and we wanted to take it a step further. So we did apply for a national collaborative through Robert Wood Johnson, and luckily we were awarded that grant. And what we're trying to do with that is to deepen what we've learned in sanctuary and build mindfulness into the staff. We're trying to teach them to truly be present. And I think this is an extra step that we have to add to this. And we can do some sort of mini things, just simple things like stopping when you open the door of the exam room and taking a breath. And when you go in, the patient knows you're fully engaged with them. You're not working, your mind isn't working on other things. And this is quite an endeavor because you can't dictate you'll be mindful. So how do we start this? And we're using sort of the way we did sanctuary in that we sent a group to Harvard to learn about mind-body care in primary care, and now have a steering committee and a core team that's trying to move this forward. Another piece is we find it somewhat frustrating and disappointing that when students come, they don't know about trauma and toxic stress. And even some who will come and say, oh, I've just had my mental health class. I said, so you know about this. and they say no. And so we've made an effort to put it in the curriculum in the College of Nursing Health Professions. We're making sure all our students have this. It seems like such an oversight. People don't understand physiological problems that are caused by stress, that all our students need to learn this. So what would I suggest to other places in other cities is that sort of everybody get on board, but again, that it's not added on. It's a normal piece of ourselves, what causes us illness and problems, and that it doesn't necessarily have to be singled out. It should be embedded in what we do. What I think is that you need a multi-sector approach. I'm somewhat frustrated because, for instance, we're working with the Spring Garden School, and I would love to get in there and be able to educate the teachers and the counselors and do something in the school. But with everything, there's not enough time. And I think another one of the problems is to look at communities is the work will take place in one sector, and the benefits will be seen in multiple sectors, yet they don't make that investment. So sometimes it falls on the health sector and the mental health sector to do this, and they're not going to see an immediate outcome, but it's going to be in the school system, in the juvenile justice system. And if we could get on board and somehow share this, I think another wonderful program I see, if we talk about resilience and strong families, is the home visiting programs. And if we could expand something like the Nurse Family Partnership, which has 35 years of research and has shown to be effective, and I forget exactly what it is, but something like $4 saved for every $1 invested. And if that could be available to more young families and moms, I think that would go a long way. Much of the work we do in screening is prevention, and maybe catching a problem early and trying to work with a child or adult or family before it gets to something with a DSM diagnosis. And yet I have to write grants all the time to fund prevention. And if that could be somehow woven into what we do, it would be cost effective. And I know people are looking at it and perhaps don't quite know how to do it. But I think that's very important, and also reimbursement for the creative arts therapies. The ACEs study, or Adverse Childhood Events Study, it gave us important information to use at the center. It's 10 questions, and we did do the full replication of that and found that 49% of the adults who come to our center had 4 or more ACEs, which is fairly serious, and we know about the cumulative effects. So we said, we need to really find out what's happened to people and ask these questions as part of our care. And the interesting feedback we got from some staff, and we get from people outside saying, how are you managing that, is, okay, you ask that, then what do you do with the information you've gotten? And I sort of equate it to years ago when we said we need to screen people for domestic violence, and many providers said, oh, that's opening a can of worms, what will I do? And I have to refer people someplace. I think we need to look at the ACEs scores in a similar way, and either have services at your site to address it, or have very strong collaborative relationships with someone that you can make a referral to, where the person can trust them and not have to necessarily repeat their whole stories again, or they're not going to go. In adults, especially in the prenatal, we do the full ACEs because it really lets them talk about, in a safe way, because we do group prenatal care, they're in small groups and they've learned to support each other, to talk about how those things have affected them and what they don't want to see repeated for their children. Because these moms are used to us talking about ACEs, when they come in for the well child care, we ask the question at each visit, has anything happened to your child that's upsetting? It's not the exact question, but since your last visit. And they're much more open to talking about it because they know why it's important. And we build that in from the very beginning. So these questions aren't like, why are they asking me that? Or are they going to report me somewhere I'm not going to tell them? They know why we're asking, and that we're asking to give them the resources they need to address it. We're also working with Nadine Burke-Harris, testing out her ACEs questions with our young children and with our adolescents. So we find it very, very important to ask questions. It's interesting in that the Institute of Medicine did their phase 2 report on psychosocial screening and putting them in EHRs. And they looked at ACEs and decided that that wasn't something they were going to ask because it wasn't actionable. And they usually ask one question about trauma and stress. And so we're often going back and forth on, do we ask those questions because your ACEs is not going to change, or do we ask something else to find out about the response? And we're right now somewhere in between at looking at the usefulness of both. I don't know if this fits in, but I feel strongly about it. So the use of the word trauma, and I think we have to say trauma or toxic stress, because so many other people, especially you find it with the specialists, when you say, you know, what role might trauma have played in their immune problem, or what role might trauma have played in something, they'll say things like, were they in an accident? Was she dropped as a baby? And it sometimes can be frustrating when others don't know about trauma and they see it in a physiological accident or something happened. And if we are trauma-informed at the health center, we want the specialist to understand that. And I think that's where sometimes there's a problem. I think the primary care in pediatrics is understanding it, and then the specialists see it, you know, as only their physiological piece and aren't as open sometimes to working with us to understand that. I may be pie in the sky and thinking what a trauma-informed city in Philadelphia would look like, but I think we would value more people. People wouldn't feel invisible anymore, both for their everyday lives and for the things that have happened to them. I think people would be open about their experiences. We would have less community violence. We would have everyone on board, and the sectors would be more collaborative, and there would be a better flow of information between health centers, schools, police, juvenile justice, housing, and people would not be blamed for things, and I think they would be better understood and valued more.